Good day, everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health here in the United States. It's my pleasure for the coalition to be joining with ICE-HBV to present the webinar, Bridging Science and New Therapeutics for Hdb Elimination as we target hepatitis B and hepatitis C for elimination. It's my pleasure to be a co-moderator today along with two others, and I'll turn over to one of those co-moderators, Mara Dondry, to give you more information about the agenda and participation in the webinar. Mara?
Yes, thank you, John. Good morning, good afternoon, good evening, everybody, and perhaps also Happy New Year to our audience in China. I'm Maura Dandri, full professor at University Medical Center Hamburg-Eppendorf, so in Germany. I'm basic translational scientist with the main research focus on viral hepatitis, particularly B and D. But today I'm also here as a member of the ICE-HBV board. And I give over the word to Massimo Levrero.
Hi to everybody. My name is Massimo Levrero. I am a professor of hepatology at the Lyon University, and I lead a research group on hepatitis B and hepatitis D molecular biology here in Lyon. I'm also part of the ICE-HBV board, and under this role, I welcome you to the webinar today.
Okay, maybe I can just let me give you some short instruction and short overview of the agenda. So please, everybody, keep your micros off. Send the questions to the speaker and also later on to the panelists using the chat, please. I remind you that the meeting is recorded. And well, we have a very dense agenda, so we have 3 talks from well-known experts in the field. We might allow actually one very short burning question after each talk, but please I would like to remind you that we will have time at the end of all talk for a Q&A session, and then in the last 30 minutes of our webinar, we will have our roundtable discussion with 5 additional experts. But before we go to the speakers, I would like to ask our panelists to introduce themselves very quickly. Thank you. Who would like to start?
As panelists, my name is Cihan Yurdaydın. I'm from the University of Koç at Istanbul. I was previously at Ankara University, moved to Koç University in Istanbul in 2019. I'm interested in viral hepatitis, hepatitis B, hepatitis delta, and I have publications on treatment, in particular on delta hepatitis. Thank you.
Stefan, would you like to move on?
Yes, my name is Stefan Urban. I'm a professor for translational virology at the University Hospital in Heidelberg. We are interested in entry of hepatitis B and delta virus. And we have developed during the last 15 years the entry inhibitor bulevirtide. And especially now with the focus on delta and innate immune responses of delta and delta therapy and diagnostics.
Thank you. Next, perhaps, Marco here?
Antonio.
Or Antonio, go ahead.
Hello, hi, this is Antonio Bertoletti. I'm professor of the Emerging Infectious Disease program at Duke US Medical School in Singapore. I've been working on hepatitis B and also delta immunology for several years, and my main interest is immunopathogenesis of viral hepatitis. I'm glad to be here. Thank you very much.
Thank you. Jeff Glenn is around.
Yes, I'm Jeffrey Glenn, a professor of medicine and microbiology and immunology at Stanford University. My lab, we focus on development of novel antiviral therapies, and I've been very interested for many years in advancing 2 drugs for delta hepatitis, lonafarnib and interferon lambda.
Thanks. And we have also Manale.
Yeah, my name is Manal El-Sayed. I'm professor of pediatrics and chair of pediatric department at Ain Shams University in Cairo, Egypt. And I'm founding member of Egyptian National Committee for Viral Hepatitis. I've been working on viral hepatitis in children for more than 30 years now. And my focus is mainly on hepatitis C and B, but also Delta, because it's we do not have any means for diagnosis or therapy for pediatrics.
Okay, thank you very much. So I think we can start. I would like to give the word to John Ward to introduce the first speaker, if we manage to come to our webinar.
Maura Rizzetto is experiencing difficulties in connecting still. So I suggest you to introduce Dieter, and we will come back. We will have his talk perhaps at the end. We will see. I'm trying to help him to connect.
Of course, of course. Thank you. Okay, then it is my great pleasure to introduce Professor Dieter Glebe. He's head of the German National Reference Center for Hepatitis B and D viruses at the University of Gießen, Germany. So I would say he's a pure virologist that also discovered and characterized new species of Delta-like virus and hepatinoviruses. So I think well aware of the role of genetic diversity and infection, is also well aware of the diagnostic challenges we have in the Delta field. So please, Dieter, we are really looking forward to your talk on virology and diagnostic needs.
Thank you very much, Maura, and thank you everyone for inviting me here. So what I will try to do now is to look for the presentation mode. Okay. So can you see my presentation in full presentation mode?
Looks perfect.
Yes.
Okay, thank you very much. So I will directly go into the details. Now we look here at the hepatitis B virus and the hepatitis D virus, and they are interconnected. And so they are interconnected by co-infection of their target cells, the hepatocytes within the liver. The hepatitis D virus here on the left side, also called the Delta virus, it is a defective RNA satellite virus that is dependent on Hbv, that is depicted here on the right side. So the Delta virus can replicate independently in the hepatocytes within the liver, but it does not encode own surface proteins. So secretion and infectivity is determined by the surface proteins of the co-infected Hbv that serve as the helper virus. So in summary, Hdv and Hbv share identical surface protein, and both viruses infect hepatocytes within the liver. And HBV chronic infection, monoinfection, usually with mild clinical symptoms, while superinfection with HDV worsens the clinical outcome. So until, let's say, recently, two dogmas dominated and also limited our thinking about this virus. So dogma number one was HDV can only use surface proteins of hepatinovirus for secretion and infection, and dogma two is even simpler, there is no other Delta virus. So at the hepatocyte that you can see here, HDV and HBV both bind to heparin sulfide proteoglycans, followed by binding towards a high affinity receptor anti-CP. And this is a physiological bile acid transporter that you can depict it here. Together with other cofactors, hepatitis B virus is taken up and the core particle is then transported to the nuclear pore. And here the disassembly occurs and the viral DNA genome is converted to a covalently closed circular DNA. And this CCC DNA, it stays episomal and is packaged by nucleosomes that regulate their transcriptional activity. From the CCC DNA, the subgenomic RNAs for HBV subviral particles are transcribed and are translated at the ER and secreted at subviral particles that we know of as HBs antigen. From the CCC DNA, most important and genomic overlength messenger RNA, the pregenomic RNA, is transcribed that also encode for the core and the polymerase. And together, all three parts are encapsulated into core particles where the reverse transcription occurs. And subsequently, the budding and secretion of virions involve multivesicular bodies. The HBV genome is also integrated within the human genome, but in linear form. And this is more or less a dead end for the virus because it's not allow replication of the virion, since no overlength pregenomic RNA could be made, but subgenomic RNAs that encode for the HBV surface proteins still be produced from the integrated HBV DNA. And this is crucial and essential for HDV. So going to the Delta virus, after uptake of the Delta virus, the RNA genome is transferred into an antigenomic RNA by a process called double rolling circle amplification that involves the DNA-dependent RNA pol 2 of the cell, the Delta antigen, and the Hdb RNA ribozyme, here indicated by the scissors. And from a single open reading frame of the HDV genome, the small delta antigen is produced that more or less speeds up the replication process of delta. However, in order to get access to HBV surface protein, HDV needs another protein. But it encodes only for one single open reading frame, so a little trick is necessary here. And with the help of the cellular enzyme ADA1, the stop codon UAG of the small delta antigen is edited within the antigenome. And this is symbolized here by the little keyboard. And after replication, this results in a UGG codon in the respective messenger RNA, encoding now for tryptophan and an around 19 amino acid carboxy terminal extended form of the delta antigen that is now called large delta antigen. And the three component, the genome, delta genome, the small and the large delta antigen form a ribonucleoprotein particle, an RNP, that is coated with HBV surface protein and secreted into the bloodstream. So from the point of view of the Delta virus, 2 points are important here. Number one, enter an HBV infected cell via NTCP. Number two, get access to HBV surface protein at the ER. And as mentioned before, active replication of HBV in these cells is not absolutely necessary as long as HBV surface proteins are produced from integrated HBV DNA. So even in the absence of an active CCC DNA, integrated HBV DNA can support a Delta virus budding with surface proteins of HBV and subsequent secretion of infectious particles. So this strong association with the HBV virus was changed in 2019 with the observation that HDV could also use surface proteins from other envelope viruses for budding and secretion, like hepatitis C virus or dengue virus. And the HCV was given special attention because it is hepatotropic, similar to HBV, can cause chronic infections. And indeed, HCV envelope proteins support secretion and infection in hepatocytes in vitro and immunodeficient mice repopulated with human hepatocytes. But concerning the clinical setting, one small study claimed to have isolated one patient viremic with Delta virus and HCV, but other larger studies have not found evidence for this phenomenon, at least in humans. So clinical data question efficient HCV, HDV only co-infectant in patients. So the next revolution in HDV research occurred in parallel. Since the discovery, Hdb was always connected with HBV and no Delta-like virus was ever detected. Starting in 2018, Hdb-like RNA sequences were discovered in vertebrates and even invertebrates by screening transcriptome libraries, and they showed a similar feature to human Delta virus, but were independent to hepatnoviral infection. But the question at that time was, do HDV-like viruses exist in mammals besides humans? And no Delta-like sequence were ever reported in mammals infected with their specific hepatnoviruses in the past. And the group of our collaborators, Andrea Rasche and Felix Drexler in Berlin at the Charité, could not detect any Delta-like sequences associated with the newly hepatnovirus species that we characterized together with them recently. So, but well, together with a group of Christian Drosten from the Charité in Berlin, we isolated and characterized a Delta-like virus directly from this neotropical rodent, spiny rat in Panama. And we ruled out any mammalian HBV, but the role of a spiny rat hepacivirus as a helper virus is still possible. Well, getting a sequence is one thing, but to analyze its biological function is another one, as you all know. And that's what Nora Goldman from my lab did. She cloned the rodent Delta-like RNA and demonstrated autonomous replication of this Delta-like virus even in human hepatocytes. Well, more HDV-like sequences in mammals have been found by screening metagenomics and transcriptomic data sets recently, but they could only be detected in mammals originating from the Americas. Most interesting, at least for me, is the fact that the woodchuck harbors its own hepatnovirus. It's been known for a very long time, but it also contains a Delta-like virus, but they are presumably not functionally interconnected. Phylogenetic, these mammalian Delta-like viruses are more or less related to human HDV, and they share a common ancestors. Now, going to the diagnosis of the Delta infection, we can distinguish more or less two settings here, a co-infection and superinfection. The co-infection here leads to viral clearance over 90% of cases, but can cause severe acute hepatitis. At the onset of the infection, HBV DNA, HBs antigen can be detected. So as HBV DNA and the Delta antigen. During the immune response and clearance of liver cells, here illustrated by increase in liver enzymes, here ALT in serum, antibodies against the Delta antigen and HBC are detectable, IgM and IgG, and clearance of HBs antigen usually indicates then recovery from acute B and D infection. On the other side, the superinfection is defined as an HDV infection of already chronic HBV infected persons, the HBs antigen carriers. Here, HDV can either be cleared in a minority of cases or lead to chronic HDV infection. In diagnostics, anti-HDV IgG in serum is a first-line screening assay for any HDV infection. The active replication of the Delta virus is then determined by measuring Hdb Rna genome, and quantitative RNA levels helpful for therapy outcome. And anti-HDV IgMs and genotyping is not routinely used. Of course, monitoring of all the HBV markers should be done in parallel, like HBs antigen, anti-HBC, and viral load. One should also think of looking at the status of HCV and HIV, especially in known risk group. Several commercial and in-house RT-PCRs exist today to detect HDV RNA in serum, qualitative and quantitative. However, there are some challenges in HDV RNA detection. This is, first of all, the RNA extraction method, manual versus automatic extraction, standard and controls. We have a WHO standard for HDV available, so however, only genotype 1. Internal controls are also necessary. All the others concerning primer probe design rely on more or less conserved region of the Hdb ribosome or the delta antigen. However, everyone could please keep in mind that the secondary structure of the complete Hdv RNA genome might be different with the 8 different genotypes that are present. Very recently, one assay was developed by Mauro Dandri's group in Hamburg. They implemented a quantitative RTQ PCR assay within a high throughput system that allow low limit of detection with a very dynamic linear range, including inclusivity of all 8 known Hdv genotypes. As National Reference Center, we contribute with the cloned Hdv genotypes from our Hdv genotype panel. However, please keep in mind with all the device Hdv RNA genome, as this international standardization harmonization is still needed. And the ultimate goal would be an easy accessible point of care Hdv RNA test, especially for low income countries with very limited healthcare infrastructure. And going into this direction, the group of Stefan Orban has recently developed an easy accessible point of care test for anti-Hdv antibodies, IgGs. This is a lateral flow assay. It contains a recombinant pan-genotypic delta antigen combining epitopes of all known 8 all-known Hdv genotypes. You see it's reacting very nicely with the different genotypes, and it can be upgraded with a HBS antigen test line, and this is useful for, at least useful for low-income countries with limited healthcare infrastructure. With this, I want to summarize. I've shown you that the Delta virus, hepatitis D virus, is a hepatotropic human satellite virus that is dependent on HBV co-infection in the liver. The Hdv has a small circular RNA genome encoding for only one open reading frame, that's the delta antigen. Hdv replicates independently in hepatocyte, but needs surface protein of HBV for secretion and infection. The Delta virus could also use surface proteins other viruses, HCV, but clinical relevance is questioned. Related new Delta-like viruses are not associated with hepatinovirus and are not hepatotropic. Diagnostic of HDV infection, anti-HDV IgG as a screening test, and HDV RNA for active replication determination. For all quantification of HDV RNA, please be aware, standardization, harmonization of the diverse assays is needed. Ultimate goal, easy accessible point of care test for Hdv RNA for low-income countries, limited healthcare setting, similar to the point of care tests for the antibodies against HDV that is available. And with this, I thank you for listening. Thank you.
Excellent, Dieter. Thank you so much. That was an excellent presentation. Great overview of the life cycle of HDV and the existence in other animals. Let's move on to explore the epidemiology of hepatitis D infection. We'll be hearing from Dr. Pietro Lampertigo, and he will be introducing himself. Pietro.
Thank you very much. Hope you can see my slides.
Yes.
Okay, thank you very much for inviting me. My topic will be epidemiology and the natural history and clinical features of hepatitis delta. These are my disclosures. I will briefly cover epidemiology and all the challenges that we have today to estimate the current burden of delta infection, natural history, clinical features, and I will summarize my results. Let's start with the prevalence. Well, I have to say that it's very difficult to define the real prevalence of hepatitis delta globally. These are two very nice papers being presented or published, the top one in 2020, the lower one in 2019. So, very short distance one from the other. The top one is estimated 12 million delta positive patients or individuals. The lower one, a completely different number, between 62 to 72 million people. And these two studies, of course, are using different methodologies. You see the number of studies being included, but the major difference is driven by the 4.5 delta prevalence among all S antigen positive patients in the top paper versus the almost 15% in the lower one. On the right-hand side, you see the two slides summarizing the global distribution. And I guess there are two main messages. One, the two papers agree on the fact that there is uneven distribution of this disease. The second point, however, some of the countries on the top paper have no data, while the same countries in the lower panel have data. And actually, it's true also the opposite. So it's not clear to me why there are such a huge difference between these two papers. And actually, the third very important paper, which has been published very recently, 2020, by Miao et al., again, looking at the global prevalence of Delta in the general population, being estimated being 0.8%, and the global prevalence of Delta among S antigen carriers being estimated at approximately 13%. Overall, 48 to 60 million Delta infection globally, again, similar to the one of the two previous papers. And in this paper, there are three countries, China, India, and Nigeria, according to this study, that are those countries with a very large prevalence of Delta infection. And if you consider the last paper I showed to you, you might be able to try to even develop or identify or estimate some sort of a regional prevalence of hepatitis Delta, 10 million Delta patients according to this study in China, many other Delta patients in US and Europe. And for Italy, there is an estimation of 49,000 Delta patients. In my view, this is a gross overestimate, or at least what we think is the current epidemiology of Delta in Italy. But there are, many, many variables that should be considered whenever you try to estimate the global or local prevalence of Delta. And this is really a challenging task. On the top part, you see not enough testing for Delta in S antigen positive patients. This is for sure something true. I will not show any data, but some of the data are going to 10% to 50% of the S antigen positive patient being tested for Delta only. So this is a major problem. The other problem is that not only S antigen positive are not tested for Delta, but this is the situation for Italy. There are many S antigen positive patients in Italy that have never been tested for hepatitis B actually. So whenever you calculate the relative proportion of the percentage of Delta patients, if it's 10% of the S antigen positive patients, actually, if you consider on the top, overall, it would be 45,000. But if you consider only those really that not to be S antigen positive, the number is much lower. And this is another major important variable that you have to consider. This is probably true not only for Italy, but for sure across many countries. The second very important issue is diagnosis. Diagnosis is not made on antibodies only. You do require Delta RNA, and all the studies, epidemiological studies, are done on anti-Delta seroprevalence, which does not correspond to RNA positivity. Probably, 70% of the patients anti-Delta are RNA positive, but it really depends on the clinical setting problem. So another very important variable to understand all these data is that these data have not been generated with the RNA. And the previous speaker also suggested how sensitive is how difficult could be to have a very good test for specific quantification and pan-genotypic quantification of Delta RNA. But there is another very important situation or consideration you have to keep in mind whenever you look for global or regional prevalence. It's very important the clinical setting you are looking into, or the clinical setting where you use your antibodies. On the left part, if you test Delta in blood donors without liver disease, you will see 2 to 8% of Delta positivity. If you go in cirrhotics, this proportion will increase by 10 times, from 51 to more than 80%. So the message on the right-hand side is very simple. There's a linear relationship between the proportion of anti-Delta positive in vertical axis and the clinical setting you're looking, you will see this positivity from 5% in those without liver disease to up to 40% in those with very high severe liver disease. And these have been highlighted very nicely by Mario Rizzetto in a recent publication, where he looked at the prevalence of anti-delta in S-antigen positive carriers in the last decade in Africa and also in Asia, Central Asia, East Asia, and Middle East. And you have to look at the color of the numbers. Blue means anti-delta prevalence in those without liver disease. Red numbers means prevalence in those with liver disease. And there is a major difference, 10 times difference approximately, again, highlighting how relevant is the clinical setting if you want to define the epidemiology of hepatitis delta. This concept has been highlighted also by this Miao paper. Very importantly, on the left side, the prevalence of delta in acute hepatitis B, 10% approximately in acute hepatitis B, which is not our experience, but maybe this is the experience in other centers, and 30% of fulminant hepatitis B are delta co-infection, according to this study. But I think, in my view, it's very important, the panel on the right-hand side, the prevalence of delta among chronic S-antigen positive carriers. Approximately 5% in the inactive carriers and 20–30% in those with liver disease. But please, let's think carefully about these 5% inactive carriers. I don't remember in my life 30 years, a single case of delta in my inactive carriers. Well, this could be a selection bias or it could be a referral bias for sure. The other issue you have to consider, the denominator here is completely different. Among 250 million hepatitis B patients, probably 200 million or 180 million are inactive carriers. But 5% of this is a huge number. If you consider the 50 million with chronic liver disease hepatitis B, well, then you have 10–20%. So if this is true, most of the delta patients probably are normal, have normal LT levels, which I don't think is the case. Another very important point is time. You cannot use the data that we generated 20 years ago, 30 years ago, to generate epidemiological or global prevalence data. This is Italy again, 1987. This is age distribution of anti-delta prevalence. At that time, the prevalence was very high in young patients and very low in older patients. Now, 2014 is the opposite. Prevalence very high in older patients and very low in young patients for several reasons. Could be a survival bias or survival benefit advantage, could be a referral bias, but there are at least two other very important issues. One is migration, and this is true for Italy, but it's true for many countries, at least in Europe, probably not only in Europe, US probably also. So this is the situation in Italy. Italian-born patients, the prevalence of delta declined from 20% 1987 to 6.4% more recently. In parallel, there's been a major increase of the prevalence in migrants, not Italian-born, from 10% 1997 to 26% now. So it's very important that you do your studies, epidemiological studies, also in these difficult to reach populations such as migrants. But there is another point you have to consider, another variable which is crucial to define the current epidemiology is vaccination. Again, Italy is a good example of this. Vaccination started back in 1991. This is the Seieva registry for acute hepatitis B and delta. You see a progressive decline of the acute hepatitis B, progressive decline of acute hepatitis delta with very few cases now, also because of the vaccination. But also this study was very important to show that intravenous drug abuse is not anymore a risk factor, at least in Italy, for acute delta hepatitis, while the most important, the only independent factor is a risky sexual behavior, exactly like hepatitis B. So things are changing very rapidly. What about the natural history of hepatitis B? Well, I think there are two different situations. On the left side, you see the co-infection. On the right-hand side, you have a super-infection. In terms of co-infection, 81% after acute hepatitis will basically spontaneously clear both viruses. So a very benign outcome, which is the opposite of the 30% only of spontaneous clearance with a super-infection. 19% will develop a chronic hepatitis if they are co-infected, with only 2% progressive to chronic hepatitis, cirrhosis, and decompensation. While the opposite for superinfection, 70% will develop to chronic hepatitis, and the vast majority, overall 54%, will develop chronic hepatitis, cirrhosis, and cancer. So overall, most of our cases with chronic hepatitis probably are coming from a superinfection model. Let me spend 1 minute on the natural history of hepatitis delta. This is another very nice paper from Miao et al. Let's concentrate only here for now. The proportion of patients developing chronic hepatitis to cirrhosis was estimated 54% over 3.3 years, which is my view means 100% of the patients over 6 years. I don't think this is correct. This is not our experience. We published a nice paper 10 years ago. Our data are completely different from this. What about the proportion of patients developing from cirrhosis to cancer? 14% over 4 years is 4% per year. Again, our data are far away from this. I think here we are overestimating the progression of delta, probably because of selection bias. Another way to estimate the natural history of hepatitis delta is to compare the natural history of delta with HPV, monoinfection. So blue means reference HPV, red or pink is delta. So 2-3 times more cirrhosis in delta compared to B, 3 to 6 times more cancer, 2 more times liver transplantation, 2 times more hepatic decompensation in delta compared to B, and 2 times more mortality. But there are 2 issues here that do not fit completely. If you have such an increase of cancer, why do you have only, 2 times more transplantation or 2 times more mortality only? I would expect much more compared to HBV. And the second and very important issue is that these papers are not considering that all hepatitis B are treated with antivirals. We don't see progression to cirrhosis anymore. We don't see hepatic decompensation HBV monoinfection anymore. So I think this is really underestimating the severity of hepatitis delta. I think it's much more than 2 times per or 2 times per mortality or cirrhosis. What's about the relationship between the 2 viruses? I think in terms of virological, presentation is very clear. 70% of the patients are predominant delta on B, 20-25% are similar replication between the 2 viruses, and 5% more B than delta. But please consider that it's not always easy to define what is high and what is low for hepatitis B and delta. And second, these patterns change over time. So do not consider this as a fixed situation, but as a dynamic situation. Please also consider that some specific features for delta are present. For example, splenomegaly. This is kind of usual for delta. This is not always associated to cirrhosis. I don't know why. There are many autoimmune stigmata of features. Many patients coming to us with delta are on steroids because of the autoimmune liver disease, which is secondary to delta. Rapid progression of cirrhosis, probably not always. And there are some specific virological features, low DNA, in my view, higher S antigen levels compared to HPV monoinfected. And very recently, we have defined a unique feature for delta, completely different for HPV monoinfection, very high correlated antigen levels and very low or negative 9% of the patients of pre-genomic HPV RNA in the blood. So finally, ladies and gentlemen, colleagues, the prevalence of delta infection remains poorly known globally and regionally, in my view. And this is because of the several challenges to estimate the real global local epidemiology. I mentioned some of the issues, testing, time, migration, and so on. The severity of liver disease may have been overestimated for several reasons, but compared to HPV monoinfection, in my view, the severity of liver disease, delta liver disease, has been definitely underestimated because the widespread use of oral therapy for HPV. In my view, to improve delta outcomes, the priority is to screen for delta infection patient with advanced severe liver disease to identify candidates for antiviral therapy, which means to go to a pathological clinics. Thank you very much for your attention.
So nobody was stepping in.
Yeah,
John.
the next presentation.
Oh, he's here.
Oh, good. Hello, Mario.
Hello, I'm sorry, but I don't know what happened, but here I am.
It's good to see you, Mario Rossetto. I think, Lindsay, if it's possible, I guess we'll seize the moment here and go up to his presentation that was to be there we go. Mario, great to see you. Please introduce yourself for those who do not know you and begin your presentation, please.
Yeah, well, yes, now presently I'm honorary professor of gastroenterology at the University of Torino. I retired from active work 5 years ago, and this is what remains of me so far. That's it. All right. Good afternoon, everybody. Can you carry on, or shall I carry on? Can you carry on with the slide?
If you just want to say,
we have
please,
your slides up.
Your slides are up. If you just want to say next slide.
Next slide, please. Next slide, please. Right. I was to tell you about what is new, or what are the current questions compared to what we had when we started. You all know that in 1980-99, the HDV was characterized as defective, strictly hepatotropic virus dependent on the HPSG of the HBV. Replication, which made the virus unique, was driven by RNA polymerases of the hepatocytes, and the clinical point was that it was highly pathogenic. So in keeping with my talk, what is now, how things have changed now? Things have changed because in the last 3 years, HDV-like virus, which means sequences of Hdb RNA significantly similar, not identical, of course, to the Hdb RNA of humans, have been found in many at this stage, non-human species, birds, snakes, amphibians, invertebrates. And none of this has been associated with the partner virus. So what is the current dilemma? What is the perspective? The perspective, of course, that from a human-centric infection, strictly dependent on B, so co-evolved with the HBV, now the perspective is that HDV, the evolutionary pathway of HDV is divergent from man and from his helper virus. And the feeling is that HDV-like agents probably have been associated with animal hosts for the entire evolutionary history of the metazoa. In clinical terms, the question is HDV transmissible then to men with other helper viruses? So are there other human HDV RNAs with other helper viruses, if any, or perhaps also with a particular genetically printed molecule? That's my fantasy, maybe. Well, there's a wider range, of course, of potential co-infections that we probably did not think about. And so this is one dilemma and one challenge for the future. The next, please. Now, I didn't hear Massimo Lampertico, but I think he reasoned about the global prevalence of infections also. Empirically, we estimated, as in the first years after the discovery of HDV, that there were about 15 million infected patients. We were estimating empirically 5% of the HPSG population. This of the global prevalence of HDV is something very still to be clear. It's very, very, very vague. And as you see, this is highlighted by the fact that there have been 3 important meta-analyses in the last 3 years. And in this meta-analysis, the the meta-analysis of the world prevalence of HDV, the prevalence, the rate of the infection has varied from 12 million to 72 million. So clearly there's a lot to do yet to clear up what is the prevalence of Delta, of the hepatitis D, through better, no, I didn't ask for that. Can you go back? Okay, in any case, for improving the recruitment methodology, improving the quality data, which is clearly not sufficient to give an adequate perspective, and getting also information from other countries, for many other countries where we don't yet have any data on Delta. The next, please. Now, the only certain information that we have is that in the yellow area of the world, as I say, I couldn't hear the presentation of Pietro, but if he presented data on this issue, I hope we agree. On the yellow areas of the world where HPV vaccination has been implemented since long and has achieved optimal results so far, so Europe, North America, Australia, and also in most of South America, simply because historically in the lower part of the country, in the yellow part of the country, HPV has been poorly represented always, ever. Well, in the yellow part of the country, in the yellow countries, we know that the prevalence of Delta now is very low. The infection is vanishing, as a matter of fact, in Europe, is vanishing in other parts, in high-income countries. And the paradigm is Italy. Italy no, can you go back? No, please, go back another second. Go back, okay. That's it, keep this one. So I go back. In a yellow countries where HDV is vanishing, we calculated that in Italy, the most likely figure for Delta infection in domestic native population is no more than 10,000 people. But in these countries, migration is bringing back the infection through workforces coming from areas where HDV is endemic. Then there are areas where the prevalence in yellow green is intermediate, because obviously vaccination has been applied also to many other countries, is less standing than the vaccination in Italy and Europe, but it's producing results and diminishing the prevalence of Delta. Then in green, dark green, there are areas, most of Africa, many parts of India, and even China, where the prevalence is supposed to be intermediate, but the data are unreliable, especially for selection bias. And then in red, instead, where the prevalence of HBsAg is very high, then the prevalence of Delta is also high. See, however, that in many parts, especially for instance in Indonesia and Southeast Asia, there are gaps in knowledge of the prevalence. The next, please, the one you were seeing before. Can I have the next? The paradigm of Italy is instructive because in 2017, the proportion of HDV positive native Italians younger than 30 years was only 3%. That's why I'm saying that in the next generation, probably in native Italians, Delta will disappear, as well as in all other high-income countries which have a successful vaccinations of long standing. And however, HBsAg immigrants with HDV liver disease are increasing. In a recent paper by Strofolini, there were 6 times as many as the Italian native patients with HBsAg positive liver disease. This is the epidemiological situation, but this gives you where are the people, where are the patients which will in the future need therapy. The next, please. Then you're going to discuss this extensively, and I'm going to deal very much with this, but of course, treatment is one of the current highlights. What is in my opinion, of course, the major point to be established. The major point to be established is what are the therapy endpoints and strategies. The hard endpoint in therapy of hepatitis D is the clearance of the serum HBsAg by the fall of serum Hdb RNA, because as long as HBsAg is there, even minimal infinitesimal traces of Hdb RNA in liver, undetectable by current assays, can recapitulate infection. But of course, this hard point is very hard. The therapeutic point is very difficult to achieve. However, with new therapies, we hope that this is so. And so one challenge is the device finite therapy with the goal of undetectable Hdb RNA and HBsAg loss off treatment. Then, of course, there are surrogate endpoints. In my opinion, the only one valid is Hdb RNA undetectable, though there is persistence of the HBsAg. Here you don't know if you'll have relapse, there is still enough Hdb RNA to recapitulate the infection once you suspend therapy. And of course, this depends on how sensitive is your RNA assay. The more sensitive the RNA assay, the less you risk reinfection, because the more probably is that the Hdb RNA undetectability represents lack of clearance of the Hdb RNA. So if we use these surrogate endpoints, we can have a finite therapy, of course, to be sure that you have eradicated Delta, you need a prolonged and eventful follow-up after therapy. Or you can go long-term, as you go with HPV, with therapy adjusted to maintain latent, clinically inactive Hdb infections. I think that you're going to discuss this exhaustively later on, but these are obviously the perspective of the current challenge of therapy. I'm finishing. I have the next one, please. I only had 5 minutes, so probably overrun them. What are, in my opinion, the major highlights? First, we know a lot about the biology of Delta by now, but we do not know about its pathobiology. Is there a role of immunopathology? Is there a role of T cells which function is apparently depressed in hepatitis D? This is a hot point. Second, raising alert to infection in countries where Hdb remains endemic. This is not only a statement there. Remember that WHO has ignored the problem of hepatitis D until a few years ago. Still in if I remember, 5 years ago, there is just 2 lines of mention of hepatitis Delta worldwide. Then one major point is avoiding selection bias in the epidemiology. There's a lot of confusion in Africa, in Asia, where Hdb is endemic, about the real prevalence of the infection. But just remember that anti-Hdv, which is the instrument by which we, antibody to Delta, we make screening, is percentage-wise 10-fold higher in HBsAg cirrhosis than in asymptomatic HBsAg carriers. What does it mean? That if you go to the blood bank and do convenience screening for anti-Delta, the blood banks and HBsAg carrier symptomatic, you will obtain a prevalence of Delta, which is probably 10 times less in endemic areas than the one you would obtain in liver disease. And data discrepancies in prevalence of the infection throughout the areas where Delta is still highly endemic probably depend from this selection bias. That's one recommendation, is to do reflex testing for anti-Hdv in all HBsAg carriers with liver disease. I could only see the last slide of Pietro Lampertico, who's mentioning that we have to test severe liver disease for Delta. I think new evidence we have is that you should test everybody, even as mild liver disease, because we might have missed mild liver disease simply because we are Delta liver disease, simply because we went always to severe liver disease because we thought that Delta was exclusively associated with liver disease, advanced. But probably it's also there when the disease is still commencing. So reflex testing is the best way to overlook hepatitis D in areas, of course, where this the infection, hepatitis D infection, hepatitis D virus infection is prevalent. Now, remember, however, a final point in terms of therapy, that contemporary hepatitis D, as I said, and as I suppose Pietro has said, is predominant in migrants and poor countries, is no longer a problem in native population or rich, high-income country. Thus, therapy, if you think about therapy of hepatitis D, you must think about a therapy which is accessible to the disadvantaged, both in terms of logistics and of costs. That's it. Thank you.
Thank you, Mario, for your presentation. Yes, it was somehow a pity that you stepped in later and you could not introduce the whole webinar, but everything was to the point. Very nice presentation. A good thinking about the history of Delta, the changes over time. I remember to everybody that actually we would not be here if you didn't discover it in a way. Obviously Delta would have been there anyway, but thank you again. And now it's my pleasure to introduce the next speaker. We will come back to all the panelists soon for the discussions. And the next speaker is Marc Bollier. He will speak on innovation in therapy. Marc, please introduce yourself and give us your presentation.
Thank you, Massimo. And as you know, I'm a pathologist in Marseille. I'm also in charge of the screening and the research program in the NRS, the French National Agency for AIDS and viral hepatitis. So my talk today will be on innovations in Hgv therapy. So this is my disclosure slides. And as you all know, since 30 years, the treatment of hepatitis delta is mainly based on interferon and PEG interferon, as it is recommended by all the guidelines coming from EASL, ASLD, and APASL. However, how they obsolete due to the poor performing of interferon. And if we look at the result, the global result of interferon in HDV patients, we can say that Hgv Rna undetectability is only achieved in 33% of the patients at the end of treatment and 29% at the end of follow-up. Moreover, late relapse occur in 50% of the patients, and globally only 10 patients had HBs antigen loss. So clearly we need to have new treatment for Delta. So recently there was a new definitions for treatment goal for clinical trial in HBV and HDV. And so there is the new definition of the combined virological and biochemical response. That's mean that we had an Hgv RNA decline of more than 2 log from baseline, or either Hgv RNA undetectability associated with ALT normalizations, either at the end of treatment or during the long-term follow-up. And this new goal came from the experience of interferon, in which achieving this goal was associated with a reduced morbidity and mortality. And that's why these new definitions have been put online. So currently, we have new therapeutic target for HDV. And there is currently 4 drugs that target these new things. So the first one is bulevirtide. Bulevirtide is targeted the NTCP receptor, so it's an INTRI inhibitors against HBV and HDV. The second drug is the lonafarnib, who block the farnelizations, which is an important step in the viral cycles. And the third drug is the interferon lambda, which is an antiviral adjunct and an immune modulator. And the last drug is the nucleic acid polymer, who leads to reductions of HBs antigen subviral particle release outside the hepatocytes and can inhibit their replications therefore. So let's move to the first drug, bulevirtide, and this is the only drug that has been currently approved by the EU for the treatment of Delta. And in the first phase 2 study, bulevirtide was studied either on monotherapy or either in combinations with PEG interferon for 48 weeks. And in this small study, you can see that the best harm was achieved and the best response was achieved by the combinations of pegylated interferon plus bulevirtide 2 milligram subcutaneous daily. And with these regimens, they achieve a 53% of Hgv RNA undetectability by the end of treatment and the end of the follow-up. and 73% of combined virological response. In terms of monotherapy, there was the result from the 2 milligrams arm with only 6.7% of Hdv RNA and detectability by the end of follow-up, but 33% of combined virological response. And clearly that showed that monotherapy with bulevirtide needs to be given for a longer period of time. And this was associated also with a biochemical response, either with the combined therapy of pegylated interferon plus bulevirtide, would lead to a 47% of ALT normalizations at the end of the follow-up, and 20% of patients reached this point with bulevirtide monotherapy. And in terms of safety, the drug was very safe, and the only issue was an asymptomatic increase in bile salt during treatment in almost all patients, and a decrease of bile salt after treatment cessations to baseline level. So these results allowed to plan longer durations of treatments, either in monotherapy or in combination with PEG, and that's it also to the authorizations market. We have also some experience with the use of bulevirtide monotherapy for HDV patients in patients with cirrhosis, and that's come from the Milans group, who demonstrate with long-term use of bulevirtide monotherapy at a high dose and then at a lower dose. They were able to achieve Hdv RNA indetectability in all patients, and this virological and biochemical response maintained 3 years over bulevirtide even after dose reductions. More interestingly, there was a regression of small esophageal varices and a recovery of HGV-related autoimmune features with no adverse events. So that appears to be a quite safe drugs. So that's led to the approval in the use in September 2020, and the drug was authorized for patients with fibrosis F2 with elevated ALT or F3 and above, and patients with compensated cirrhosis, and of course, Hdv RNA positivity. The dose used and recommended is 2 milligrams daily in combinations with NUC in patients intolerant or contraindicated to PEG interferon. And the duration is not really precise into the approval, and it's over 48 weeks. So we get now some real-life data coming first from the French early access program with bulevirtide. In this program, 145 patients were included, and 133 patients were analyzed. And as you can see, people were either treated with bulevirtide monotherapy, 77 patients, or with combination with PEG, 68 patients. Most of the patients were cirrhotic patients, and most of them were using current NUC in combinations. And if you look at the virological endpoint, undetectable Hdv RNA or more than 2 log reductions from baseline at month 12, it was achieved in 94% of patients with combinations therapy and 68% in patients with monotherapy. And if we look at the combined response, undetectable Hdv RNA or decrease more than 2 log plus normal ALT, this was achieved in 39% of the patients with bulevirtide and 30% of the patients with combinations bulevirtide plus PEG. We have also the experience of the use of bulevirtide monotherapy in patients with advanced cirrhosis in the real-life setting. And that's come again from Italy, in which 18 patients with advanced cirrhosis were treated with 2 milligrams daily of long-term bulevirtide monotherapy. And you can see that after just 24 weeks of treatments, 47 patients achieve Hdv RNA indetectability, and 76% of the patients as a combined response with both the virological endpoint and ALT normalizations. Moreover, there was no impact on HBs antigen loss. The level of antigen HBs remained equal during all the treatments. And there was a very good safety profile with no adverse events, no bulevirtide discontinuations. So again, very good result and a very good safety issue. So there is still some question mark on how we need to use bulevirtide. Is there a combination of bulevirtide plus PEG useful, even if you prolong the combinations therapy by monotherapy with bulevirtide for 48 weeks? Is that difference to the result obtained with PEG or with bulevirtide monotherapy? And in this MIR 204 study, we have now interim results from the week 24. And the interesting point is that clearly what's happened is that in this setting, there is no difference between 2 milligrams and 10 milligrams. So clearly 2 milligrams appears to have a similar effect at a higher dose. So that's the first interesting information. Of course, what we are waiting for is really waiting for the primary endpoint and to see if we are able to obtain a finite treatment duration with this combinations therapy. The second phase 3 study is the MIR 301 study, in which they look at the bulevirtide monotherapy for 2 or 3 years. And in this study, we have only the interim result of 24 weeks. And again, what we see is that there is no difference between 2 milligrams and 10 milligrams. And again, we can really speculate that the 2 milligram dose is the dose that we can really use due to the fact that the combined response is completely not different. Of course, we need to wait for the final result of the studies. Moreover, in this study, they were able to demonstrate with a pair biopsy from 79 patients that after 48 weeks of treatment, there was a significant decline of delta antigens in hepatocytes. And this the decline of the expressions of delta antigens in the hepatocytes is associated with expressions level of innate immune and inflammatory genes would decline in both treatment arms to a similar extent. And globally, that demonstrates that bulevirtide also diminished liver inflammation in these patients. So now let's move to the second drug, which is lonafarnib. For lonafarnib, there was a dose ranging and dose finding study which have been recently published. And coming from this study, there was only 2 doses of 2 regimens that appears to be interesting. The lonafarnib 50 milligrams BID plus ritonavir 100 milligram BID, and the same regimen in association with PEG interferon. And you see the study was very small with a very few number of patients treated for 24 weeks, but leading to a very high decrease of viral load or Hdb Rna undetectability associated with normal ALT level. So that's lead to the concept of with lonafarnib that maybe we have a therapy guide by baseline Hdv viral load. For those who had a viral load over 4 logs, it might be interesting to look to a combinations treatment. And for those with a lower viral load, lonafarnib, ritonavir monotherapy, all oral regimens may be of interest. And of course, this is studying on the ongoing phase 3 study. We test these 2 regimens in comparisons with PEG interferon for 24 weeks. But we will get this result only in 2023. The next treatment is lambda interferon. And for lambda interferon, we've got a very small study would demonstrate that PEG lambda was well tolerated, better tolerated that in terms of side effect that the conventional PEG interferon alpha. The right dose is the 180 microgram per week. It achieved 36% of undetectable Hdb Rna at the end of the follow-up after 48 weeks of treatments, and a very similar result for ALT normalizations and quite similar for the both endpoint. However, there is a safety issue with this drug because they have a high rate of hyperbilirubinemia grade 3 and 4 in 10 patients, mainly in Pakistan, with no clear explanations. And so we need to look a little bit more deeply into this data. We have also the data, the phase 2 study of PEG interferon lambda associated with lonafarnib and ritonavir for 24 weeks in a small phase 2b study in 26 patients. And again, in terms of virological response, we had a very good end of treatment response with 77% of the patients who had a Hdv Rna decrease of more than 2 log, and 50% of the patients who achieved undetectable Hdv Rna. However, 24 weeks post-treatments, 23% of the patients remain undetectable. And interestingly, in this study in which there were pair biopsy, there was an improvement in necrotic inflammations in 55 patients. But again, we find the same safety issue with 5 treatment discontinuations for hyperbilirubinemia or ascites for 1 patient, and also a lot of adverse of gastrointestinal adverse events that is maybe one of the issues that we have with lonafarnib to deal with. Now let's move to the last compound, which is the NAP. And for the NAP, the REP 2139, there is only this phase 2 study on 12 Moldavian patients with chronic Delta infections with no cirrhosis. And clearly, and this regimen was given for 15 weeks, and then in combinations for 15 weeks with PEG interferon, and therefore it was followed by 33 weeks of PEG interferon alone. And with this compound, they were able to achieve a serum Hdv Rna undetectability is in 11 patients under treatment. And after treatment cessations, the Hdv Rna undetectability was maintained in 7 patients. More interestingly, and for the first time, this compound was associated with a loss of HBS antigens in 5 patients, 6 during treatment and remained 5 during the follow-up. And the appearance of anti-HBS antibodies in 5 patients that were maintained 1 year after the cessations of treatment. The only concern with the use of REP is the occurrence during treatment, either on the REP monotherapy or on the combinations therapy with PEG of ALT flare, but this ALT flare were never associated with bilirubin increase or ANR increase, so no signs of liver deficiency. Moreover, this cohort was then followed, and we have a long-term follow-up result of the use of the REP in this study. And after 3.5 years follow-up, 65% of the patients remain Hdv Rna undetectable, and 8 with normal AAT, 6 with a declining or normal hepatic stiffness, and 4 of the patients had HBS seroconversions. So this result was maintained with time, and there was no occurrence of adverse events such as hepatocellular carcinoma. That could be something that can be asked due to the mode of actions of the drugs. So one of the big problems with this drug was the use as an intravenous drug in intravenous perfusions weekly, and now we have the use of subcutaneous REP 2139, and we use it in 1 patient who were cirrhotic patients, non-responder with to bulevirtide, in a regimen in which we combine all the 3 drugs, PEG, REP, and TDF, and we achieve HBS RNA negativations very early on treatment, and at week 14, HBS antigens disappeared and anti-HBS appear, and now is around 250 international unique of anti-HBS. Again, they have some issue with ALT flare, but no increase in bilirubin, and there was this a problem with side effect due to the injection site reactions, and this is very common when you are doing oligonucleotide injection in subcutaneous way. So globally, in conclusions, I will say that PEG interferon is definitely suboptimal. Currently, bulevirtide is the first-line treatment with NUC, and is the only treatment which have approval in Europe. There is several question marks about the bulevirtide dosage. I think that if you look at the data coming from the phase 2b and 3, the 2 milligram dosage may be sufficient. Monotherapy, okay, but how long do we need to use monotherapy with this drug? And that's an issue. Maybe we have some response from the phase 3 trial. And the combination with PEG is something which could be interesting, and but there is still a question mark of whether or not we need to use it in combination with PEG and for which durations. And again, the phase 2b study will give the answer. For the lonafarnib, we share exactly the same questions. So that means we don't know if we will be able to give the all-oral regimens and for how long, and do we need to combine it with PEG interferon. For PEG interferon lambda, it may be useful if PEG interferon is needed. However, the issue of hyperbilirubinemia need to be explained and more deeply before we can use this compound in phase 3. For the NAP and the REP 2139, it's a very promising agent. Of course, larger studies are urgently needed. And of course, what we need to think for the future is that we maybe need to think about combinations of those 3 drugs, and that's need to be evaluated. And also we need to evaluate the combinations of those drugs with new combinations for hepatitis B, such as the RNA silencing agents, who could be helpful in order to reduce the HBs antigens level. Thank you for your attention.
Thank you, Mark. I think that Maura, you can go on the questions. There are a few questions to Dieter.
Yeah. Very well. Yes, we will come back to the issue, I think, from the panelists with interferon and therapy. But I would like to have some 1 or maybe 2 short questions, hopefully short, we'll see, to Dieter. Actually, one is coming from an Avalon. It's about what is known about different genotype, HDV genotypes and clinical outcome.
Okay, as we already heard, there are 8 different HDV genotypes, and there have some studies have been made, but in the past there were usually very low amount of patients involved. But I want to highlight the study of Dominique Rouleau et al., who last year investigated a large cohort of a French cohort where they looked at genotype 5 from Africa and genotype 1 from patient from Europe. And this was a study in Journal of Hepatology in 2000. And what they've seen is that both the European patient of genotype 1 and the African patient of genotype 5 had an elevated risk of developing cirrhosis. So and they concluded in their papers, they concluded that the place of birth, the HDV genotype, and persistent viremia constitute the main determinants for the liver involvement and response to treatment of chronic HDV infected patients. So it's not only the genotype, but it's also your genetic background, your place of birth, and other comorbidities that contribute to this. And I think this is a great study, and more studies related to these African genotypes has to be done in the future with very big patient cohorts. But maybe the clinicians have a better papers or studies for this.
Thank you. Thank you for your answer. Well, if there are not further comments immediately on that, I would like to move on with an interesting, quite challenging, I think, question that Heiner Wedemeyer was putting in the round, which maybe is not only for you, Dieter, can maybe also in the panelists, somebody else step on, because it's actually, again, virological more questions. So about, do we have explanation somehow? What do we know so far about how HDV actually suppresses HBV, what is often observed? And also more specifically, can also the Delta antigen protein interfere with the HBV life cycles? I think they're very complex kind of.
Who wants to answer? I can answer. Stefan, yeah.
Maybe
do you want to comment?
A short start with the in vitro data that we have if we co-infect in the absence of an immune system, cell lines or primary human hepatocytes. So we do not have much of evidence that either expression of Delta alone interferes with HBV replication. The entry is not, there's no cross competition in entry. So you have co-infected cells, you have mono Delta infected cells if you co-infect, and you have B-infected, mono-infected cells. So to all what we so far know, it seems to be the interferon response that is heavily induced by Delta. Then in a second round, this is probably also what you see then in the mouse model of Maura, maybe you comment, then really acts on HPV. I mean, we know that interferon in an established HPV infection does not play a very important role, but it is profound, yeah, in the next step, so the early step of establishing of a B infection. So it's a kind of cascade that probably then leads to the suppression of HPV, mostly in Delta infected patients. Then, of course, the adaptive immune response that comes in.
Yes, thank you. It is true also in the humanized mice, we more observe the kind of very light, still half a log sometimes, very often, of a reduction of HPV, but not a strong suppression. So in patients, something more is happening, definitely. Anybody wants to join in this, add some comment, or we move on?
I think we had one comment about for Pietro, who presented a variety of data for the prevalence of hepatitis delta, and we began to touch on some of the methodologic differences and other limitations explaining those differences. But I noticed in the chat that Malika Toy from Stanford is in the audience and has some experience with those studies, and so we're going to seek to elevate her to panelist level so she can provide her comments and questions directly. Malika? Please go off mute.
Can you hear me?
Yes, loud and clear.
Yeah, thank you for the great presentations. I actually, so I enjoyed watching Dr. Lampertico's presentation, and I do agree with the underestimation, overestimation of some of these epi surveys. So I have not done an epi survey myself, but I've written a editorial on this. So I've studied looking at a few of these surveys. There's not much I can add to both of those slides, but so it is yet to be determined, I guess, the real burden of HDV epidemiology. But I do believe that both or all three studies have done have taken a step towards that direction. So I think they're to be, well, somehow congratulated, and for us to actually even talk about this right now. Yeah, that's all.
Okay, thank you, Malika. Well, one other comment in the chat was that some of these estimations sort of extrapolated data from high-risk populations to be representing the whole country. Want to see what Pietro thought about that comment. And then another concern I've had in some of these, which is relevant to diagnostics, is the quality of the test, not just the test itself, which the quality of tests can vary also. So Pietro, please comment on these limitations and others.
Thank you very much. Yes, the first question is from Anna Maria Guerretti, and I think it's very well placed. Actually, my whole lecture was really, in my whole lecture, I tried to challenge a little bit all the findings that we give for granted. And again, exactly, one of the issues that you cannot extrapolate one single country, one single city, one single region prevalence to the whole country. And at the same time, you cannot extrapolate the prevalence of Delta in cirrhotics listed for transplantation to, of course, the whole population of hepatitis B. Absolutely, I agree 100%. I think we have to provide data in this specific subset of populations. Otherwise, we will never understand anything. And probably we also need new data and not rely on the old data anymore, really, because things have changed very much. In terms of diagnostics for the anti-Delta, I think probably Dieter will eventually make a point, but I think the more recent anti-Delta, diagnostics are much better than the previous one available. So probably this is not a major problem today, but Dieter, this is your job, really.
Yeah. Dieter?
Yeah, I think so. That the diagnostic tests for the Delta antigen for the antibodies, the IgG, are very good, and so the question is only with the quantitative viral load determination. This has to be given careful consideration.
Thank you,
Dieter and Massimo. Dieter, can you comment on whether it's more a question of sensitivity or reproducibility or inclusivity for all genotypes, the issues with the Hdb RNA. Can you just give us a flavor on this? Where is the problem for the PCR?
I think it's all three. I think it's all three that you mentioned, and the very big problem that we have is really the specialty of this RNA. It's a circular RNA, and it binds more or less to itself, so it has a complex 3D structure. And to get this 3D, and this is different with every genotype and every variant, and so you have to be very careful how to place your primers and probes and what to do to really put these two strands from one another so that the primers and probes can bind. And this has to be evaluated. And I think this now becoming discussion now, but this has to be evaluated by having the whole RNA genome. That's also what Maura's Dandri work has shown sometimes recently, that you need the whole genome to really to have a reference if this is working correctly.
There is another question that I see in the chat for you, editor. And after I will give the word to the others for another question. But there is Mary Afian that asks, consider the fact that the Hdb prevalence is very high in sub-Saharan Africa. How can we have affordable access to Hdb rapid testing?
Well, this is this is not a question for the scientists, but for economics. But of course, we should have some kind of Hdv antibody rapid test. But the ultimate goal for me would be a point of care test for the Hdv RNA. Probably can think of it or discuss this later. There are some possibilities that this might be true.
We will come back to that.
Yeah.
We will come back to that in the general discussion. We will involve also the other panelists. Maura, there is one question for I think about therapy for Mark. Yes, the question is, can you say more about the duration of suppressed and detectable viral load with the new treatment combination? Are you able to say if Hdb RNA continues to be suppressed or you have as many relapses as before with interferon? You presented some data there with the long-term treatment from Italy, but there were very few patients. Mark, can you comment more on that?
I think that currently there is a lack of data regarding this point. I mean, we have data on treatment, we have data, and the only data that we have is coming from the phase 2 study on bulevirtide, in which you see that the best result is obtained with the combinations of PEG plus bulevirtide, who still have a long-term response, at least for the 6 months post-treatment. We have no data on long-term response after 6 months. And clearly, we are waiting for the data coming from the phase 2b and the phase 3. And for lonafarnib, we have no data. I mean, it's a lack completely of data. And the same is true for lambda. So the only compound for which we have long-term data is the NAPS, for which we have the long-term 3.5 years. But the problem with NAPS is that there is a lack of affordability. The drug is produced in a very small amount. There is still issue on the mechanism of actions, even if it's more now understood, but there is still, we don't know which protein is really a target by the NAPS within the hepatocytes. And so there is some questions about that, but clearly these compounds appear to be very interesting. So the subcutaneous form is something that could be useful for wider use. It's an oligonucleotide. So oligonucleotide is something which is quite tough when you administer it by subcutaneous route. But if you do it carefully, it's well tolerated. That's our experience that we have. But we need to increase this experience. So clearly, it's funny because there was an approval for a drug in which we have very few data coming from only the phase 2 study. And the same is true for whether or not we are going to be able to use bulevirtide either on monotherapy or either in combinations with PEG. It's very hard to conclude now, and we need to have the result of the phase 3 study.
So we are almost in time with the schedule, and I think that is now time to move to the general panel discussion. And I would give the word to Maura to start it, and after myself and John will animate as well. Go ahead.
Okay. So, well, if we start discussing, maybe, I don't know, because, yeah, we have also a list of potential questions here. One, I think it could keep us busy for hours, but let's try to come to some main points. So actually, the discussion about interferon and Hdb therapy, alpha, pegylated, or different interferon, I mean, this is something that clinicians don't want to have around, but trial says it helps. So please, maybe we can start maybe with Jeffrey Glenn, or who would like to discuss about the role of, if there is still a role for interferon Hdb cure?
Yeah, I do think for now, interferon still is going to be important. I think Stefan can comment later on some of his studies of the mechanistic basis for why we might need that. I think, however, I mean, clearly interferon is synergistic in some cases, additive, depending on what compound it's added to. In terms of the alpha, but I think in terms of patient tolerability, the lambda is dramatically better. And in the lambda study in Delta, I would say about half those patients had been on alpha before. They had to quit their jobs, they were getting divorces. And when they were on lambda, they said it was really like night and day. So I think if you're going to use an interferon, the tolerability for patients of lambda is really advocating for its use. And that phase 3 study is now underway, and I think that will eventually lead to that drug being available to consider in any combination where you want to use interferon, either in Delta or even in HBV. But that's a longer discussion. Mm-hmm. By the way, the other great aspect of lambda, which has nothing to do with Delta, but we will soon be hearing the phase 3 data on the single dose treatment of COVID with interferon lambda, which I think will also be very impactful for another virus that's been bothering us these days.
Mm-hmm. Yeah, I'd like to add and bring one aspect in that we haven't discussed so far. We should always think for clinical efficacy in the mode of action of a drug. Yeah, and especially with the question to interferon, I find it very interesting to see that interferon, from all what we see in vitro and also in mouse, it has a direct antiviral effect beside its ability maybe to modulate the adaptive immune system. And this also comes back to the new Delta viruses that we see. Interferon is blocking the spread of Delta by cell division. We should keep that in mind. Delta can propagate by cell mitosis, and that is probably the default pathway of all the Delta-like agents that Dieter discussed. That means we don't need, it's a special thing that the human Delta uses HBV envelope proteins as an additional way to spread, okay? And here we have space for bulevirtide and for lornafanib to interfere with, but the interferon is doing a direct effect. And we should look at that, and that under that aspect, we may need it, yeah? To accelerate and to make drugs faster, but we should also think this is not interferon per se, it's the interferon response. So we may have drugs that are developed for HBV, TLR agonists and other agonists that do the same job as interferon in Delta. So we should see it from a little bit more distant view to have something that is inducing the interferon response and something that is inhibiting spread for therapy. And whether that then leads to affinity therapy, we don't know. We will see.
Thank you, Stefan. That was a very nice point as you made it, obviously.
May I just shortly add a comment, or also to Stefan? I think, don't you see that if, I think it's very good, it's very reasonable to think about if we enhance the innate responses and we have cell division, then probably Delta virus will get more fragile, let's say, right? So, but anybody knows how much really now we have cell division in the context of a liver that is not anymore highly inflamed as we have it at the beginning of treatment. But let's say if like with bulevirtide, we see that we have a normalization of ILT, then yeah, can you comment on this?
The point with bulevirtide monotherapy is we normalize ALT levels, so we do not have a lot of inflammation maybe going on, but still we have a exponential loss of infected cell, telling us the half-life time of these cells, because we really think we eradicate the infected cells by that treatment. And if that is quite fast, 500-fold reduction within 24 weeks, in mean, that's okay. There is a much higher cell turnover under non-inflammation of Delta infected cells. That's the good news, and that makes us hope that we can eliminate. Whether that works, I don't know. But we should have still to see, this is different for any individual patient. The slope of the curves are different, telling us that obviously half-life times of infected cells for some reason that we don't understand so far. But this is what I guess. And that's also the reason bulevirtide is slow, because it depends on the cell turnover and not on the antiviral direct effect. It depends on the cell turnover.
And Stefan, we must remember that the more fibrotic the liver, the more towards cirrhosis, the more senescence is there in hepatocytes. So yes, they will proliferate less. So it's a composite scenario that we have to take into account. But let's try to go back a little bit to the original. It was a beautiful discussion. We can stay there the whole day. I know this because we did it several times, discussing these more mechanistic aspects. I would like to shift rapidly to the, we evoked that a few times, but what is the role of the immune system in Delta infection? I would like to have Antonio kicking in and give us some perspective from not only the innate immunity and interferon or interferon signaling modulating the whole HDV host interaction, but also on adaptive immunity. There has been a lot of new information. And Antonio, can you give us what are the lessons from immune response studies? Is there a role for immunotherapy? Whatever you want to tell us.
No, thank you. So I think when we are, let's say, talking and we want to speak about immune response against Delta, in reality, we are talking about a mosaic virus because it's HBV antigen and Delta antigen. And therefore, I do think it's important to make a couple of points. One, what is the HBV-specific T-cell response in patients that are chronically infected with Delta? Well, again, we know very well that in patients, particularly in adult patients, old patients, the HBV-specific T-cells is very, very reduced. Particularly is reduced the response against S antigen. Therefore, in this aspect, let's say the Delta is unlikely to be very well recognized. However, there have been very nice studies recently. There were two papers in gastroenterology, one from the group of Barbara Rehrman, the other one from the group of Neumann, Heflin, Robert Tim, Roggendorf, and Ulrike Protzer, that actually have shown in reality that T cells specific for Delta antigen are present, but not only are present, are actually able to select the viral mutation, which is telling us in a way that the T cell response against the Delta antigen is present and is able to do a sort of selection. And here I would like a little bit to go back to the innate immunity, because here is important, again, what also Stefan said, that, you know, the Delta virus in reality is not a virus that is evading innate immunity like hepatitis B, but is a virus that is activating innate immunity. And the innate immunity in this sense clearly is important for the blocking the replication, but we have shown that the lambda interferon gamma is particularly good on increasing antigen processing of endogenously produced antigen. So basically, we have we can see in vitro and also in a mouse model that when you are, let's say, double infected hepatocytes with the infection of Delta and HBV, the antigen of HBV is presented much better. Therefore, in a way, we can even think, you know, I was thinking about the question of Heine-Wiedermeyer, whether there could be additional mechanisms that can explain why hepatitis B virus antigen and hepatitis B in reality can be reduced when there is Delta. Of course, there is innate immunity, one, but there could be also the fact that the Delta is, in a way, a sort of adjuvant, a sort of immunogen for the antigen presentation. And in some patients with chronic hepatitis B, even though, again, the T-cell response is reduced, there are still T-cells specific for polymerase, for core, particularly, let's say, antigen that are produced in lower level. And this effect of Delta on boosting antigen processing can be an effect of, let's say, why then we can see a reduction of hepatitis B. So that's, I would say, my main point. But in general, again, if we are thinking that, again, the Delta can actually boost the antigen processing of antigen, and I want to remind everybody that the hepatocytes are very well known to have a very low level of HLA class 1 and HLA class 2, therefore are somehow target cells that are difficult to be recognized by T cells because there is, in the absence of inflammation, a low level of class 1. So in general, I would say that any sort of immunotherapy that it can boost antigen-specific T-cell response, and I'm thinking, for example, of checkpoint inhibitors, I think there could be a clear role on the Delta HBV infection because, again, Delta, as I said, is boosting the antigen process of the viral antigen, both hepatitis B and Delta. Thank you.
Let's get some others involved in the conversation here. I wanted to open it up to Chihan to give, he may have a question or a comment on discussion to date, but just wanted to get your experience with Delta in Turkey and how these new therapies are available in your experience with them. Thank you.
Well, I mean, I think Delta hepatitis is a disease of developing countries. It is a disease of within the country of regions where the economy is even worse than the general economy of the country. So it is a disease of poor people, poor countries. And in that sense, new therapies, which we are talking about, such as bulevirtide or the new drugs, nucleic acid polymers, lonafenib, pegylated interferon lambda, and so on, we will not see them for a reasonable time period. So in that sense, interferon is still a drug which has to be seriously considered under these conditions. It is very easy to recruit patients into phase 3 studies nowadays in these countries because people see that as only the hope to get proper treatment. But with an interferon, we can have reasonable treatment if the patient is treated by a wise hepatologist, I would say. It is important for interferon treatment that, if possible, the patient is followed by on-treatment parameters such as Hdb Rna. If Hdb Rna on treatment at week 24 is, and it is important to look at week 24 of treatment. If you have a 2-log or more decrease of Hdb Rna, it is likely that this is a patient who is going to respond to interferon and you can continue with treatment. On the other hand, if the patient has a less than 1-log decrease of Hdb Rna, the patient is unlikely to respond. And for these patients, you have to look for other possibilities. Now, if we treat a patient for, there's one thing I have to say that in general, there appears to be no room for prolonged treatment because, as we have shown in the HIDD-1 and HIDD-2 studies, there was I mean, these were different studies, but the HIDD-2 studies, which last 2 years, it appeared that there was no response, no difference in terms of viral response between the 2-year and the 1-year HIDD-2 and HIDD-1 studies, respectively. So in that sense, it does not make sense to prolong treatment, but there is also some data which suggests that prolonging treatment is beneficial for some patients. So if a patient has a 2-log decrease of Hdb RNA or after 1 year of treatment, and you stop treatment, the ALT will go up, the Hdb RNA will go up, and it is not the right way to do so by stopping treatment with pegylated interferon. If possible, you should continue in these patients by similar to bulevirtide for indefinite period until you have the so-called functional cure of delta hepatitis, which is surface antigen negativity. So this is one thing. I mean, this is what I can say about treatment of delta hepatitis in developing countries or in many countries around the globe currently, because as far as I know, bulevirtide is approved in the UAE, but it is available actually for treatment on the basis of reimbursement by the state insurance in Germany, Austria, France, and I think Italy. And that's it. Please correct me if I'm wrong. So it is and I have patients from Georgia, Azerbaijan, former Soviet Union countries who cannot get hold of bulevirtide, although it is probably also available in Russia. But once it is not reimbursed, it doesn't mean anything for the majority of patients because it's expensive still. So these would be my comments. And the same holds, by the way, the same holds true for the issue of epidemiology. I mean, this is the source of delta hepatitis is from endemic countries. Endemic countries are developing countries, and the data on HDV prevalence in those countries are not optimal data. And the analysis, which was the global epidemiology data, is based on these insufficient data. And on top of that comes the issue of selection bias. On top of that comes the issue of not paying attention to chronological order. Therefore, I think there is an overestimation of HDV prevalence globally. And the last publication from Stockdale is more fitting to the current epidemiological prevalence data on delta hepatitis. That's what I think.
I agree. Thank you. Well, Noel, let's come to you. A number of questions come to mind for you regarding what's the estimation of delta for Egypt, number one, since you're sitting on the national committee. Is delta becoming part of the conversation for policy and planning and that program planning in Egypt? And I know you have a particular concern about children, so I feel free to comment on that as well. Thank you. And you're on mute.
Right. Thanks a lot, John. And I really appreciate all the presentations for Egypt. Actually, the estimate is between 8 to 10% co-infection with hepatitis B. But it's not part of the conversation. And as you know, we did not even introduce hepatitis B screening within the national screening program of Hep C. But Hep B has been introduced for triple elimination of pregnant women. Now we have the screening testing for syphilis, HIV, and hepatitis B and in the Ministry of Health hospitals. I do not think that Delta is going to be part of the conversation soon because the tests are very expensive. And I think this stands for all low and middle income countries. And even in sub-Saharan Africa, I don't think this is available. The ELISA tests are extremely expensive, and not to mention the cost of the Delta RNA. So I've requested maybe Delta in very few patients who just had elevated transaminases while on treatment for hepatitis B. And very, very few over my very long experience were positive for Delta in the pediatric population. But then we're not testing enough. We're underestimating the prevalence. Globally, there are just 2 studies in the pediatric population, one from Russia showing 5% prevalence and one coming from France showing from migrants, pregnant women, 4.7% prevalence of Delta. And none of them transmitted Delta when they gave the birth dose vaccination, and they have done everything to prevent mother-to-child transmission of hepatitis B. So I think the key is prevention of hepatitis B from transmission to children, and that would sort out the problem and increasing the coverage of birth dose vaccination, which is only 10% in sub-Saharan Africa. And the other point is if we're talking about low and middle income settings, clinical trials usually do not target the population with the highest prevalence. So in Africa, for example, if you look at the number of clinical trials registered, you won't find any for Delta. There are very few for hepatitis B, and there are hardly any, or if you can find any, I didn't find any on the clinicaltrials.gov registered for Delta. So I believe that's one issue that we should advocate for, that more clinical trials and more compassionate use trials in areas where there is a high prevalence of Delta, like Western and Central Africa, for example. And the other thing, as far as the children are concerned, we're in continuous discussion with the GAP accelerator, the global accelerator for pediatric formulations, to look into what we can do for children in the future. We are working on mathematical models to predict the pharmacokinetics in children and smaller children. And I believe the key to success in production of formulations is to discuss the possibility of scored tablets from the very beginning. If you have a model, a pharmacokinetic model for the younger children, and the companies start by producing scored tablets from the beginning, this is going to make things much easier for pediatric clinical trials in the future and for treatment of children in the future. We are suffering a lot for treatment of hepatitis B in children. We don't have access to medicine for the younger age groups, even those who need treatment. And I think it's going to be the same in the future once we identify cases, more cases with Delta.
Thank you.
John, I think we are still perfectly on time with the schedule. Why don't we call for extra comments from all the panel? If there is somebody that wants to add something to the different topics, we arrange it really from a completely different perspective all around the Delta infection. That is great.
Excellent. Stefan has hand up.
Stefan, go ahead.
Just wanted to directly comment a little bit on I mean, what Jan said. Of course, the problem is that bulevirtide, I mean, the state of bulevirtide is, as you may know, it might be approved within short next month within the US. This is heavily followed by Gilead. We hopefully have that also approved to other costs in Europe. And of course, you can only hope with this beginning that Gilead is also following a policy to negotiate with the several countries and so on, and launch programs that makes that cheaper also in Mongolia, for example. I mean, this is also a political issue. I've been there for 7 days and tried to convince people, yeah, but this is a problem sometimes, as you may know. And I hope that accelerates with the COVID drugs, that accelerates with the HIV experience, etc. Regarding the point of care test, I mean, that was exactly what we were intending to do also in Egypt. Yeah, we start now by financing these test prototypes from our side without funding to start some trials in Africa, also reflex testing and so on of collected samples. Yeah, the test is still not commercialized. I mean, we are looking for partners that are coming for this test, at least that you have an individual antibody test, which is pan-genotypic, and also as a blood test, as a dipstick, so that people can test themselves with a drop of blood. Yeah, this is the state of the test development. I mean, we are not a diagnostic company, we are an academic research laboratory. Yeah, and we hope that with these kind of activities, more awareness is coming up. And also that diagnostic companies or companies that are now interested are following that and commercialize that and make it available together with programs of the WHO, probably, hopefully. Yeah, this is at least the state, but we have to go step by step. Yeah, this is.
I have to say that there is also some renewed interest from some of the big diagnostic companies on Hdb Rna. Is a completely different issue. It's not for the point of care in the first row, but there is new interest from the two majors diagnostic company into the Delta. So I think that the perspective is there. We have really to advocate.
Yes, it's
I think you advocate like we are doing today.
We are not on the same deadline as we were the last 10 years. We are on an acceleration thing. So I want to see the positive, but it still needs some time until to get something running, really.
And before giving the word again to John to close, Mario, do you have any comment from your point of view before we go to the closure?
You're asking me?
Yeah, if you have any comment or you want to say something else.
That's a very short time to talk about them.
Okay.
But we have many in any case.
Okay, thank you. John, I think it is time to close. It's up to you now.
Okay, well, thank you. We have 3 minutes. That's we have an evaluation. Please fill out the evaluation, but that's just popped up on your screen. But did want to Stefan gave some closing remarks. Just when we do have a couple of minutes, if anybody else wants to make some closing remarks before we sign off, please raise your hand. Who's on the panel?
Can I make a comment?
Yes.
What Stefan Urban mentioned about the rapid diagnostic test is very important. And it should be available in many countries. So I don't know if the World Health Organization pays an interest in those tests. I also want to mention maybe if Jeffrey Glenn could mention his serological test, which has some correlation with Hdb Rna positivity. Jeffrey, do you want to comment?
Yeah, a comment?
Sure, I think you're referring to our QMAC assay, which is a quantitative antibody capture assay for IgG to Delta. And it's a very sensitive, large range of linearity, but one of the most striking fortuitous outcomes is that there are some quantitative thresholds that we've been able to define that if you're above a certain level, you have a 100% chance of being positive on a Western blot. So we don't do Western blots anymore. And there's a higher level, you have a 100% chance of being positive for Hdb Rna. And so this is very useful for screening large cohorts, which we've done, but also for individual patients who, because in our experience, a lot of the antibody tests have a significant degrees of false positive and false negative. And so there are many patients that have been referred to us that the clinician suspects they're Delta positive, the commercial ELISA is negative. We do the QMAC and it's highly predictive of Hdb Rna positivity, and then you do an RNA test and it is D positive. So I think, but it is also not a commercial assay, but it I think shows something that could be taken up and used. Ultimately, Hdv Rna is the most important, as there's therapies now, because that's what we're going to use to monitor response to treatment. And fortunately, those tests are quite good.
So it seems we really need to keep moving in getting more, better harmonized, standardized tests at different level. So probably also different WHO standard, depending on genotype. This is that we don't have more time to discuss on this, but definitely the awareness and the collaboration really to join force and do comparative study. I think they will be very, very important.
And if I may, I think as part of ICE, I think that this is really something for ICE Hgv together with all the other forces, but this is the kind of thing around the biomarker, around science, around these things that ICE is very keen on following up. We should really, today was quite inspiring. The discussions from so many experts was inspiring to me, and I think we have to push forward exactly in the direction that Maura was saying, and that was stated by John, by Gian, by Stefan, with the existing test, with more attention to that. I think we will have to try to have an action there. I like to convert discussion in action points, and that would be a nice thing to do.
Absolutely. Yeah. Thank you all. I think we're going to have to close. I want to thank all the speakers and the panelists and the people attending the webinar. I mean, I think we're still in the very early stages of this new era of therapy for hepatitis delta. There's more therapeutic options to come, and we had a great overview of virology, clinical outcomes with the current therapies, prospects for future therapies, and some of the challenges regarding diagnostics and access in the countries that have the highest burden. And I think that we want these issues to be elevated, and I think this type of webinar serves that purpose as well. And I look forward to continued collaborations with all of you to maximize the opportunities for therapy for Delta for those at risk and living with Delta virus. The slide presentations and the recordings will be available on the ICE website as well as on the coalition website at globalhep.org. So please go there.